Thank you. All right. Welcome. Ta-da. All right, this is the start of something that has been tried at least once before September 12th. And I'm really glad that we can get this going again. My name is Tony Denuzzo. I'm with Seeley Center on Aging, and I'm the director of the East Texas Geriatric Education Center. I welcome you to this first session that's going to talk about geriatric health literacy. This series was developed based on our funding for the East Texas Geriatric Education Center with HRSA, the Health Resources Services Administration. That's who funds us. Geriatric education centers are found all through the United States. There are 50 GECs. And the main purpose of the GECs is to provide enhanced geriatric educational programs to increase the knowledge of health practitioners of all disciplines and students that are in health professions. That is the basic purpose and our statutory purposes that we try to adhere to. I'd like to acknowledge our partnership with East Texas AHEC, East Texas Area Health Education Centers, and without them, we could not possibly do what we're doing. They are in our service area that includes 60 counties in East Texas. We service 4 East Texas AHEC regions. Brazos AHEC, that is around the Waco area. We have Piney Woods around the Nacogdoches area, and also then south we go to Coastal AHEC in Beaumont, and then south of there we go to Victoria with Pecan Valley AHEC. And we are teleconferencing, I'm going to talk a little bit more about that, to all those sites. This is an active learning series. All right, this is the first of 5. And I would like to just stress that as an active learning, I encourage questions, comments. You don't have to wait till the end. If you have something you want to talk about during a presentation, at least for mine, you're welcome to do that. And I'm going to go through an agenda right there. And this is how it's going to follow. We'll have, okay, you can see that. I'm going to do about a 50-minute presentation that introduces you to the concepts of health literacy. Dr. Raji, who's director of our geriatric fellowship program, will be providing a presentation on health literacy in a clinical setting. We're going to have a 10-minute break after that to do what you need to do. One thing that you might want to do that is very important, fill out forms. There's always forms. The GECs lost their funding in 2006 because of a cut in HRSA funding. And one of the reasons for that loss of funding was that there was not good data to basically support why the GECs should stay in business. And so since then, we have had a huge effort to try and collect as much good data in terms of what our participants are doing, where they are, and how we could, it's much more than just bean counting. All right, great to be here, but we have to know what your population is that you would be serving as health practitioners. So there is a form here that is really critical. Topics, it's a participant profile. Maybe during the break you could fill that out, and all forms you could just leave on the table on your way out. Okay, so this is real important. It's for students and health practitioners. Okay. And if you have any questions about any of this, just let me know. Okay, after that break, I'll be doing a short presentation on how we assess health literacy. What are the tools that are out there that can be used to find out the level of health literacy of patients? And this is going to be an interactive thing. I'm going to show a video, and we're going to break off into groups and have a little discussion about the video, and I'll direct that as we go. Following that are evaluations, which again is very important. We have several, depending on if you're asking for continuing education credits or if you just want to evaluate how this program seemed to meet your needs. Okay. By the way, we hope you had lunch. Lunch is a new thing for us, by the way, and I'm really glad that we're able to offer it this year. We've we've been doing a lot of programs, and we've been able to secure the funds. And I'd like to thank Dr. James Goodwin, the director of the Seeley Center on Aging, for allowing us to have some of his budget to order us some food. Okay. This is the series. It's going to run for 5 months on the third Wednesday each month from 12 till 3. And these are the topics that we plan to go with. Improving communication is actually a big component of health literacy. And we have a couple of really good speakers that are going to be giving that next month on February 18th. Dr. Helen Appleberg, who is an ordained minister and a scholar for the Center on Aging, will be talking about spirituality in geriatric health education, health literacy rather. And we will also have, from a patient point of view, some older patients that are volunteers of our ACE unit, our acute care elderly, of the elderly unit. And that panel will talk about their experiences in clinics and with health providers that may be able to shed some light in terms of how it is from their side and their point of view. We have others, interdisciplinary team panels, very important what the role is as a team, barriers for culture, which is also another major component of health literacy. Insurance, how do you get optimized reimbursement? Very huge. And also health literacy in different settings. It's not just in the clinics. We have health literacy going on and needed in nursing homes. And we also cover older prisoners. And so that's another setting that we want to look at. And finally, Dr. Lee Grumbles will be working on ethics and health literacy and discussing difficult topics. And that's our last one in May. You have a flyer that has these topics that you can take with you. Okay? All right. Any questions so far? They'll all be in this room, by the way, all 5. Teleconferencing sites. Let's talk about that for just a second. Here we are. In the top left, we have Baylor University, facilitated by Amanda Thomas with Brazos AHEC. She's in there somewhere. It's hard to see everybody. One thing I want to ask is for the remote sites, when you have a question or a comment, please state your name and where you're located so we know where you are, because it's really hard to identify everything here when somebody's talking. Okay? In the top right, we have University of Houston, Victoria with Pecan Valley, and Paula Crawford is a facilitator from Pecan Valley AHEC. Hey, Paula. You could wave. Looks like, oh, there you are. Hey. Everybody from different sites could wave. By the way, I could get a little informal. I hope that's okay. Okay, and here we have Ocean View. Johnny Davis is there. She's one of our GMPs. And they're in Texas City at Danforth. Hey, Johnny. There is a slight delay of screen speed. Yeah. Bottom here in the middle, we have Stephen F. Austin in Nacogdoches with Piney Woods AHEC, and Mark Scott is our facilitator there with the Piney Woods AHEC. Hey, Mark, you could wave. I don't know why it freezes up, but I guess maybe it's doing one of those freeze ups. I don't know. And here we have Lamar University in Beaumont with Coastal AHEC, and Terry Dickerson is our facilitator with Coastal AHEC there. So everybody's up and going, and we're going to welcome, and I'm glad to see everyone. Some may be here for continuing education credits. We are offering lots of different types of continuing education, and they are all free. All right, these are all paid for by the GEC. For medicine, we are offering continuing medical education 3 hours for the 3 sessions. And with that, there is evaluation forms. All you need to do is sign in and fill out an evaluation form for each of the 3 presentations that you attended if you're requesting CME. And then leave that here. And if you want to just bring it over, if you can't have time to fill it out now, that's fine. You could do it later. Okay, so this is the CME evaluation form for those interested. Okay. The important thing with this CME is that we're considering the 5 sessions as one activity, meaning there'll be a cumulative number of CME credits given after the May session. In other words, you won't get one letter after each session. So whatever you attend, then we'll add those all up and give that to you at the end after May as one certificate. Okay? By the way, you should all have these as handouts. You know, some of these slides. That's the number for the Office of Continuing Education if you have any questions. CNE is for registered nurses. LVNs can request CNE and we will provide them with a letter, but it's not required. Again, sign in and there is a little packet for CNE that you just need to fill out with the request for credits and evaluation. Okay, it has a separate evaluation for CNE. And this is for 3.2 credit hours, contact hours. We have CEUs for social work, and that again is the same evaluation form as used for the CME. Again, just a sign-in sheet. All right, we have 0.3 contact hours CEUs for social workers that we'll be offering. CEUs for physical therapists and occupational therapists, they have a different evaluation, as if there's not enough. That's the evaluation form for PT and OT. This is also the evaluation form for everyone, regardless if you request CE credits. This is for the general evaluation that we use to improve the program and that we can report back to HRSA. All these forms are important, and this are real important. Okay, can't stress that enough, but thank you. All right, any questions regarding the continuing education credits that we offer? Okay, and I need to say, as a disclaimer, that none of our speakers today have any commercial affiliations to provide. More or less that. I think that's it. The GC website, I'd like to just show you that real quick. Oh, do this one. Ever notice how things go much slower on the network during lunchtime? There we are. This is the new East Texas Geriatric Education Center website. We've spent a lot of time revamping this and getting it so that it's current. It has information here about the lecture series and a workshop that we did back in May in Waco. Other information. There's lots of good information here that you can take a look at. And on your handout has the URL where you can find all this. The other thing I'd like to show you is this program in Basic Geriatrics and Gerontology. This was something that we did a couple years ago where we offered basic educational information on geriatrics and gerontology in a series of lectures and with these topics. And these are this is a lot of good material if you'd like to visit and take a look. For example, with the introduction to aging, we have a couple of video streamers of presentations given during that session with by Dr. Goodwin, talking about his thoughts on aging from a very experienced point of view. Dr. John Papaconstantino talks about the theories of aging from a biological point of view. And then we have a module that supplements a lot of this information that that you can look at. And this is all free. You don't have to sign in. You don't need a password. You can just go there and take a look. We're going to be adding lots of other materials as we move forward with some of this. Seems like this is going, there it goes, a little on the slow side. And this is basically for introduction to geriatrics and aging. It has learning objectives that I think will speak to how you can maybe get a little more familiar with aging and general concepts. For this session, I'd like to dedicate it to the memory of Nikki Deanne Sinclair. Nikki passed away earlier this month. She was a physical therapist who worked at our ACE unit, and she was very dedicated to her field and to the health care that was provided to her older patients. She attended many of our lectures before. She and I had several conversations in terms of how we can possibly improve the health care to our older populations in this area. And she will be very much missed by her family and friends. And so, in spirit, she's here. Okay. Running a little over. On the lighter side, I'm going to be giving a little of a presentation on how we think health literacy actually is, what it means to us, and what we can really do to incorporate that possibly in a practice and provide more efficient care to older patients. I'm not really good in giving my own bio, but I was born in the Bronx. My parents were from Sicily. I'm first generation Italian. Went to Manhattan College, got a degree in biochemistry, and there wasn't really much in the Bronx that I wanted to do, so I went to Texas A&M, got a master's in biology and micro, realized I really liked Galveston in 1980, came over here to work with sea turtles, of all things, and loved it, natural marine fisheries. But there was only a one-year program, and I worked in pathology there for a little while, and then I got a job at UTMB in 1981. And I've been here 28 years. 14 as a microbiologist, and around 93, got a master's in gerontology and health promotion here at UTMB, and started working for the Center on Aging in 93. And it's been just great. Got my PhD in early 2003, I guess. And I found education in geriatrics as being the area that I really enjoy the most. And the Geriatric Education Center has been able to fulfill whatever it is I felt I can do in education. And I love the program. I just want to ask real quick, who in this room is familiar before this with the term health literacy? Yeah, a few. Okay. So this will be relatively new for most of the people in this room. And I have to tell you that it is basically new to me. This is one of the main objectives that HRSA specified in the proposal, was to come up with programs that speak to the topic of health literacy. And it's not something that's been around a long time. About 10 years it's been around. If you were to ask an older patient, possibly, what health literacy is, I want to get back to that in a minute. It's basically about language. That's one of the main things that you may think of in terms of literacy. You can understand, you can read, can you comprehend this? But it basically is about language, but it's much more than that, as we're going to find out. But I'd like to just go over the objectives real quick. From a very basic point of view, just what are the major concepts of health literacy? And not more than just definitions, but what components make up health literacy. Why is it important? Is there data out there that supports that it is worthwhile to become familiar with health literacy and to incorporate that into your practice? And then finally, discussing the factors and challenges that can have an impact on how health literacy is brought across between patients and health providers. Okay? Very basic stuff from the beginning. And I think that this is a good place to start. So we have the patient point of view, but from a more academic point of view, and this is something that HRSA has worked on for a long time. Healthy People 2010 actually spoke to this topic. And health literacy is the degree in which individuals have a capacity to obtain, process, and understand very basic health information and services. And this is important because it could be needed to make appropriate health decisions. And we have lots of examples we could think of with that we can discuss. Many times they think, well, use of medications is huge. Right? If you cannot understand the directions to take a medication, obviously that could have an impact on the effectiveness and the outcome of a certain health condition. Okay, we're going to talk about lots of examples as we go along. Okay. Now, I want to read real quick there is a gap between health providers and patients when it comes to health literacy. And as a synopsis, health literacy is basic reading and numerical skills that allows a patient or person to function in a healthcare environment. The healthcare environment is pretty complex. I don't have to tell you that. Now, most adults read at an 8th grade level. About 20% read at or below 5th grade level. What grade level do you think most healthcare information is that's out there? Take a guess. A little lower. 10. It's at 10th grade level. The goal for many of this is to get it below that, anywhere from 5th to 8th, preferably below 8th grade level. Okay. Now, older patients are particularly affected for other reasons that may not be as apparent because the reading and comprehension abilities are influenced by their health, by their cognitive abilities, their vision, hearing, and inadequate health literacy can result in difficulty in accessing care. Having inadequate health literacy are more likely to be hospitalized among patients with even if they have adequate skills. Patients understand information if it's spoken slowly. This is something I have to remind myself all the time, being from New York, that I could just, you know. Anyone from New York would hear that. I try to talk slowly, and I will. So we have a lot of information that can be looked at from a point of view of a health practitioner if they are really aware of the level of health literacy among their patients. So it is dependent on a lot of factors that are within the person themselves, the patient, as well as the whole system. Okay. Communication, many people think, well, that's going to be crucial between a patient and the health provider. And we're going to talk a little bit more about that, but we have a whole session in February that will be talking about communication skills and how to improve those. The knowledge. How much knowledge does a person have about their health, about general anatomy, about understanding what it is to be healthy, the connection between exercise and good health habits and possibly a good health outcome. And then how does that relate to an older health professional talking to their patients and being able to bridge that lack of knowledge if there is any. Culture, I said, was very important, not only for language, but mannerisms, okay, different types of way they are greeted, okay, and so culture definitely will have a big impact on the level of health literacy. The demands of the healthcare system is obviously very complex, and how, for example, insurance. Can they fill out the forms if they need Medigap? Can they obtain Medigap? Can the patients get the care and the access that they need? And finally, the demands of the situation, the environment that they find themselves in. It could be very intimidating to be in a doctor's office. And how do they feel about being there? How you can make them feel comfortable within that healthcare environment. Okay. This is, again, remember, this is basic. So a lot of it is common sense, but a lot of it is also awareness. Okay. There's a mnemonic that you can use to remember the different components of health literacy. It's called the SPEAK mnemonic. S is for speech. How will the healthcare provider's speech be received by the patient and the caregiver? Lots of parts to this. Now, do healthcare professional patients speak the same language? Do they need a translator? Okay, if there is need for a translator, we've got to keep in mind that they just can't bring a family member to do the translation. They need a professional translator for legal issues so that they are legally protected. The hospital is legally protected from any information that is exchanged between the translator and the health professional. Okay. Perception is the P. How will the patient and caregiver perceive both the verbal and written content during the communication? What type of materials will be given so that the person can understand what is being given? Will it be verbal? I had a busted eardrum a few months ago, and it was not fun. And I had to give the health provider a lot of credit because I couldn't hear a thing. And so he brought me all these great materials about the tympanic membrane, how to treat it. I mean, right there in my hands. So I could take a look at it, and we had a limited amount of actual talking because it worked out really well. So being aware of something like that is really important. Education, the education level of a patient and caregiver. Well, you know, that's something that correlates with the level of health literacy. Okay, the level of education correlates with health literacy. I'm going to show you how to determine the different levels in a little bit. Again, current technology, there's different formats that can be used. And this is kind of interesting. Are they finding out, are they able to use a computer? Are they computer literate? Can make a big difference. Okay. Access, it is not whether you can get in the parking lot, unfortunately. Many people think that. But if there was you know, as a patient and a caregiver, can they access the system? This is really important because when I talk to older patients, something that they have a hard time with is the fact that they cannot see the same health provider on a regular basis. So then you have to start all over. They would love to see somebody who knows them. If that could happen, that would improve the access. They would feel more comfortable right from the get-go. So, and what about the environment? Is it shame-free? Do they feel comfortable within that environment, within the office, waiting for a health provider to show up? And finally, knowledge. The assessment of the health literacy, how will it be carried out? All right, how will you know that the patient is health literate to a point where they can make the appropriate health decisions? Real quick here. Okay. So, where did this all come from? The National Assessment of Adult Literacy was formed by the Department of Education to determine the level of literacy to the general population. Now, this is before health literacy. Remember, it's only been around 10 years. Well, they wanted to use printed and written information to be able to determine the level of knowledge and literacy by their general population. And they came up with the term functional literacy in terms that they were able to achieve the goals that were necessary to develop one's knowledge and potential. And this was mostly used in general literacy for one big reason: to find a job. Okay, that was the main goal for the people that wanted to get a certain level of literacy, as to be able to find employment. In 1992, that was a general literacy assessment that the NAAL did provide, all right, to the general population. This was again before health literacy. In 2003, they added the component of health literacy, and they did a representative sample of 19,000 adults, 16 and older, and they used the assessment of prose, document, and quantitative scales to determine the level of health literacy among those people. And from that, they determined different levels in terms of what was the accepted possible level of health literacy that was required to be able to make appropriate decisions. The survey results were pretty interesting. For the most part, many had a pretty low level of health literacy. About 53% had what was considered to be intermediate. Okay. In here. Okay, so they had below basic, a basic level based on an average score, an intermediate level, and a proficient level. While 53% had intermediate levels, if you have an example, for example, at below basic, they were able to do certain tasks. Okay, a task would be circle a date on a medical appointment on a hospital appointment slip. Okay, that would be one example to be able to have a below basic level of health literacy. And so forth. This is kind of interesting. At an intermediate level, they were able to take prescription medication correctly. Okay. Very interesting that would not be something you would think had to be, to me that would be basic. But that was a higher level of health literacy that was required. It was intermediate. And that was the scale that they used. at the average scale was based on 245 points out of 500. Pretty interesting. Okay, so why is it important? Well, when you look at the distribution based on other scales for health literacy, it compares very well to general literacy in terms of prose, document, and quantitative literacy. About 14% had below basic level of health literacy in this survey. Again, 53% were intermediate, and 22% had what was considered a basic level of health literacy. Okay. Now the question is, is that acceptable? How much of a difference will that make? Well, we try to look at other indicators to determine what effect looking at these different categories from below basic, basic, intermediate, and proficient may have on health outcomes. Okay, by that. So, you could look at here, percentage that had below basic health literacy. Most did not graduate from high school, so it correlates with education. A large percentage were Hispanic. Those that were older than 65, 31% had a below basic level of health literacy. 36% no medical insurance. And in comparison to others that had higher levels of health literacy, these numbers were not as high. In other words, those that had medical insurance had a higher level of health literacy. Now it's real important because it correlates with self-assessment of overall health. 42% of those with below basic health literacy also self-reported themselves as having poor health. Okay. And that's a big difference compared, as you can see right down the line, there's almost a linear correlation. 57% with intermediate had excellent health. Okay. And this is regardless of age. So the bottom line with this is that 12% of adults have proficient. Only 12% have enough, considered to be enough health literacy to make good health decisions. 9 out of 10 may lack the skills needed to manage their health and prevent disease. And that needs to change. 14% of adults have below basic health literacy, and they're more likely to report their health as being poor. They will also more likely to lack insurance and other indicators. Okay. So this is a basic problem. Got to be able to speak about what the problem is here. There's basically 3 questions that I think all patients need to ask. And that is, what's the problem? Okay, how can you describe the condition? If you're the patient, you want to be able to communicate to the health provider on what's wrong. And that could be a very difficult thing to do. Okay, there are 5 basic areas of need that when we look at in terms of how we address health literacy. Obviously, medication use. Need to be able to read if there's vision problems, be able to read the directions and be able to understand the directions on medication use to show that they are being used correctly. Okay, medical terminology, if there's terms there that are being used, how will you know that the person that you're talking to actually understands what you're saying? The patient. Very basic. Anatomy and physiology. If there's basic parts of the body that you are describing, have to make sure that they know what those parts are. Orientation to medical forms. There's a lot of forms out there. Can they fill out the forms? Do they have the necessary skills to be able to fill out a form correctly, and especially if in terms of insurance reimbursement? Patient-provider communication skills. How well does the provider talk and speak with the patient? And are they aware if something isn't getting through? Any questions up to this point? That's a lot of material in a short period of time. Okay? Okay. Okay. So there's different ways of addressing health literacy in terms of what it can improve. Obviously, if there is a higher level of health literacy, there may be more chance that they can access the information if it's on a computer, or if they find it in a library, that they could go out and find, the patients can go out and find the information. More likely to have a better access to care because they can make appointments if needed. They're able to navigate throughout the system a little better and able to complete forms better. And if there is needed informed consent, that can be done much easier because they could understand what's required during those while filling out those forms. And again, communication. These go hand in hand with the needs that I just mentioned before. Okay, so it's important because they need to navigate through the healthcare system. You can share personal information. You can engage in terms of what's happening with the disease process, and you can act on what's new out there and talk with them about these. But most important, most likely you can have better health outcomes if there is a higher level of communication between the patients and the health providers. Now, with limited skills, they're less likely to utilize different services for prevention, less likely to use emergency services, and less likely to actually be hospitalized. Higher utilization of treatment services results in higher health care costs. It's been shown that $73 billion can be saved by increasing the level of health literacy simply by going from basic to intermediate. Quality care can also be improved because there is an effect on that. Good quality care means providing patients with appropriate services in a technically competent manner with good communication, shared decision making, and being sensitive to their culture. And there's healthcare costs. This has been shown by several different types of studies, and it really does have an impact. By improving the level of health literacy, you can have an impact on healthcare costs. And obviously that's very important these days. So what affects health literacy? Well, I mentioned communication. If they are unable to read and write, obviously that's going to be a problem. So the forms that they're given, the information that they're given, can have a negative effect on whether or not they can comply to instructions for improved health care. It's dependent on the knowledge of various topics of the health provider. People with limited accurate knowledge about the body that causes disease, they may not be able to understand this relationship, as I mentioned before, between lifestyle and outcomes. This is kind of interesting. Health information can be overwhelming for people with advanced literacy skills. And why would that be? They know too much. They read too much. And so everything becomes like, oh, it's you just get overloaded with information. And that's something to be aware of. All right, culture, how do people communicate and understand? All right, and like I mentioned with culture being much more than language. Okay, how do people feel about their health? There are different cultures out there that have superstitions. There's different health, I guess we can call them syndromes that can possibly be controlled by whether or not that patient will actually seek health care. Okay. Will they seek something that could possibly do something about a condition that they feel could be possibly from bad luck, for example? How people respond, recommendations to health change and treatment may also be affected by culture. And again, the demands of the healthcare public health systems. They need to be able to understand payment options, okay, how to fill out those forms. They need to have various types of health professional services to know how to access the different types of care that's available out there. I think Dr. Raji is also going to be talking more about this in greater detail because it's dependent on the whole situation that they find themselves in. And so there's a need for empathy from the health provider in terms of this patient's there, maybe not feeling well, and it's a very stressful situation. Okay. And it may involve unique conditions such as a physical or mental impairment that has to be addressed. And we're going to talk more about that when we do assessment, where possibly looking at assessment of cognitive ability is needed for some of these types of conditions. Health situations are often new and unfamiliar, and they can be intimidating, obviously. Okay. Among older adults, well, yeah, hearing and vision. Some of this you might be able to recognize with a patient. They really can't see too well, so you want to make sure that what you're talking is very clear and very slow and very, very concise so that they can understand. If it's also affecting hearing, well, there might be a need to bring in some other form of communication. And let's see, I mentioned empathy, trust and openness. That's kind of interesting because I think it's easy to have mistrust with a health provider if it's someone who they don't feel is addressing them properly or meeting their needs or talking to them with respect. I think, though, that most do that. Most health providers that I've come across do have a respect for the patients. But with an older patient, there's something that's called elder speak. Oh, dearie, don't worry. It'll be fine. You don't want to use that. Dearie isn't good. Things like that. And there's lots of information about that with elder speak in terms of the terms of endearment that seem okay, but they are turnoffs to older patients. All right, so literacy, health literacy is not a few things that we may think it is. It's not just plain language. Now, that's the technique that's used, in terms of language that is, communicating clearly. But it is a tool that's used for improving health literacy. Culture competency is a way of measuring the level of culture that a professional has that is cross-cultural. It can contribute to health literacy by improving communication and building trust, but again, it is a tool that is used for health literacy. All right, shame. This is a big one with an older patient. They may not want to let you know that they don't understand something. They may feel a little embarrassed when they're in the clinic and say, I'm sure I understand everything. Will they really be able, will they feel comfortable enough to be able to actually tell you truthfully that they need more information and they just don't understand what they need to do? And finally, who is responsible for all this? Well, health literacy in America is a society which health systems and institutions take responsibility for providing clear communication and adequate support to facilitate health-promoting actions based on understanding. Sounds great. I don't really know what that means. But it's something that the healthcare system, I think, at this point, is trying to understand how to address this so that we can actually see improvements in health outcomes. And when it gets right down to it, the health providers may seem like they are responsible. But if you talk to Dr. Michael Warren, who is in the Department of Surgery and in Urology, he does a column in the newspaper now and then. I'm sure you may have seen it. Great guy, really entertaining. I wish he was here giving this talk. But he has really put a lot of good information out there that takes the responsibility and basically puts it on the patient. Bone up the knowledge. Go out there and find out what's going on. The health providers can only do so much. Because one thing I didn't talk about was how much time does a health provider have in a clinic to address health literacy, to actually be able to know that, oh, I got to do something about this. Can they actually do a standardized test to assess the level of health literacy? Very difficult. I don't know anyone that does that. So you have to go with other cues to maybe be able to tell that you've got to improve in communication for the patient and the health provider. But I like the idea that it's not just on the health provider, that the patients also can be responsible for understanding their own health. I have a number of resources that you can look up with this presentation. There's lots of information out there. We're getting more and more all the time because we're realizing it's an area that there's a lot that needs to be done. We could understand it, but can we really do it in practice? And there's some more. These are all in your handout. And that's what I have. So, any questions? Let's have some comments. And
I have a question. Sometimes in the clinic, we need to talk to the caregivers,
Yeah.
with patients with Alzheimer's or debilitated or, chronic issues.
Sure.
So, how does it work when we are trying to communicate with the caregiver and the patient is kind of left aside? So.
Well, I'm pretty sure Dr. Raji is going to speak to that, but my feeling on that, and we're going to see that in the third hour. The video actually shows an Alzheimer's patient with their family, and they're trying to come up with a plan of care. All right. So lots of times you deal with the families, and there also may have to be an intermediate person there, whether it's a translator, something. But how do you communicate also with the family that this is what to expect with possibly their mother who may have Alzheimer's? And the mother isn't quite sure what this is all about. Why are they here? Why are they talking to me? And but how do you make it so it doesn't get chaotic? That there's actually some progress being made for the to maybe identify resources. Yeah, how do you get that information very clearly to the family member for an Alzheimer's patient? I think is that. And you're going to see that in that video. It's a great example. I'm really glad you brought that up because that's where we're going to see this in action. And then you're going to be able to have an idea like, oh, okay, there's some real deficiencies here, and this is what I would do to improve this situation. Oh, go ahead.
Sorry.
That's all right.
Well, I was surprised that with the survey results in year 2 or 3, is that the most current
I'm sorry, can you?
The survey year in 2 or 3.
2003?
Is that the most current one?
They have another one planned, I think after 2010, with the healthy people, when they start getting the new set of goals set up. I think 2020, Health People 2020 is going to be, is already started. And so I don't know, that's a good question. I need to find out what how much they progressed in terms of getting an updated survey. Because you're right, 2003, it's getting a little bit outdated.
So this health literacy is a part of a whole literacy survey.
Right. It started off as being for prose, documentation, and quantitative in 1992, I believe. And then they added the component of health literacy in the same way with a number of tasks to be able to then score how well people did. And it was basically on the same scale as the other components of literacy. Yeah.
It would be interesting to see what those 26 items are.
Oh, yeah. I don't have a copy of it, but the remote sites, they can unmute, and if you'd like, if you can't hear the question, I could repeat it, and we can go from there. Okay. Any other questions? Okay.
You referenced the issue of consent form. Can we still say that a client is experiencing health literacy, or that we believe is experiencing health literacy, and can actually have a level of informed consent when the average consent level is on a postgraduate level, reading level?
That's a good question. The level of consent forms that are usually written try to be on a little lower level, at least the ones that we use for our surveys. We go through having about an eighth grade reading level for those consent forms. If we do this in the general public, we're going door to door to surveys. Within the clinic, I don't, Dr. Raji, or do you have with consent forms for patients that they need to sign? What are the implications if someone has a low level of health literacy and is signing a consent form? Can it be binding?
Well, in geriatric clinics, one way we go around that is by making sure we have a contribution from family and close friends, particularly if there is any possibility of cognitive impairment or in a patient whose literacy is really, really very compromised. The trick is to give the instructions even at a lower level, 5th grade level. That way, you keep it simple. You try to let the patient and the family get back to you and sort of elicit some level of consistency in their agreement or disagreement with any part of the concept. So that way, and to let it be open that whatever decision they make is the right decision, as long as they have all the information.
What I see as being a real problem is the legalese that get put into consent forms. And how do you bridge that where there is necessary language that needs to be in that form to make it binding? Yeah, Julie.
It's a topic that ethicists have been thinking and working on for a long time. And I think it gets back to what you were talking about how do you create conversations in the limited time that doctors have with patients. But originally, the purpose of the informed consent, rather than being kind of a CYA move or legal, is that the spirit of the document is to be a point to create communication, and that the form is to be used as a model to really create a dialogue between the doctor and patient.
So there's room for discussion with the form.
Right.
They review it, and they do they review with the patients to show that they really understand
And
what's going on.
Those are things we need to talk about how you actually demonstrate
that.
comprehension.
Right. And when we get to the assessment part of today, we're really going to bring out some of the deficiencies in terms of why it's so difficult, not only because of time, but what's available out there to actually measure the level of health literacy. It's a huge topic, and ethics is big. That's great. Thanks, Julie. Did that answer your question okay, over in Lamar?
Yes, it does.
Okay, thank you. It was a very good question. Anything else? Anyone else? Any other questions? Are there other sites? Yeah, Diane.
I just keep thinking, as I was watching this, how this dovetails health literacy with patient-centered care. And we had a wonderful speaker here from that studied the Mayo Clinic. And I don't know if you went to his talk, and he wrote this book about, and he practically lived at the Mayo Clinic for a while. And the Mayo Clinic is known for delivering patient-centered care. And one of the questions he asked, which really struck me, was, if you really believe in patient-centered care, would you allow someone to sit in a waiting room for 2 hours before they see the physician?
Right.
When that time could be spent with a nurse out there conducting educational seminars in that period of time. There are so many ways of dealing with health literacy through patient-centered care models and using nurses for what they are educated to do.
Right.
And so this is fantastic. I hope someday they dovetail properly where they're supposed to.
Making good use of that available time when they're just sitting idly in a waiting room is insane. I mean, you have to make use of that. I mean, that'll be maybe a form right there to fill out that could be the assessment to measure the level of health literacy.
What question should I ask a doctor? And
Right.
you can have one nurse talking to 10 patients all
Right.
at the same time. And we could be working it together.
And I wonder, though, do they have the time to actually look at those forms, analyze them well enough to make some decision in terms of what the the level is that they can, and then it goes back to, here's the form, now what do I do with it?
Because I do notice that if you bring anything written to a physician who will give you 7 minutes, they will read it.
Right.
They actually read it. So it really does help to give a physician more than oral.
Yep. The written material helps a whole lot. Anything else?
This is Lamar University again.
Okay.
Yes, I did my thesis in nursing education on health literacy. And what I found is that physicians want to know that we have to establish a baseline as to the client's level of literacy prior to being able to actually teach that person. And what we did, my chair and I, we leveled the education based upon the realm, which I think you're going to discuss probably later. I didn't win a national award for this my research. It wasn't as in depth, and I don't know if the behavior modifications lasted long enough. But I did find that assessing that client by themselves with the realm, and the average was on a 6th to 8th grade level, allowed me to teach them on their level and they understood and retained the information as far as I could see based on a pre-post-test method that I used.
That's really interesting. And why was the realm used instead of the TOEFL? Do you know?
Yes, I do know. I chose to use the realm because of the length of time involved, and although the TOEFL would have been a better tool to use, the length of time to use it in a physician's office, and I did use it in a small clinic that was providing a nurse practitioner clinic. And so with that and the length of time that I had, it gave me a rough grade equivalent score so that I was able to determine what their reading level was. And the average person, even though there were two that I had on the college level, they preferred the information on the 6th grade level because it was basic, it was simple, and easy to understand. And then you said earlier in reference to medical terminology, I also found that it was very demeaning to the average client to go in with words and big terms. And hypertension instead of you have high blood pressure. They understand basic terminology and they can relate to you and talk with you based on that.
That's really encouraging. I haven't heard many examples of that being effective like that, but that's really good to know. And I think it's going to be interesting when we do the assessment exercise to see how that would fit in. Thank you very much for that. That's really good information. Okay, we can go on. This is great. Any other comments, or everything is clear enough? Okay. I just noticed, by the way, if you're filling out the CME, we had so many forms trying to get ready for this, that the little symbols on this, that were supposed to be numbers. This is the communication thing. You got to watch your forms. You got to really look at them. And it's like I was here, it's like, what is that? I would say that would be 1 to 4. Little boxes are 1. Smaller boxes are 2. Arrows pointing to the left are 3, and arrows pointing to the right are 4. I don't know. Okay. So, okay. Wow, right on time. I'd like to move forward and introduce our next speaker, Dr. Raji. Dr. Michaela Raji, I've known him for quite a number of years, and we've become good friends. He received his medical degree from the University of Ife in Nicaragua. I'm sorry, in Nigeria in 1987. Nigeria. And a Master's of Pharmacology from the University of Alberta in Canada. Completed residency training in internal medicine at Washington Hospital Center in Washington, D.C., followed by a geriatric fellowship at Duke University Medical Center. Since 1999, he's been a clinical assistant professor with Department of Internal Medicine here at UTMB Division of Geriatrics. And since receiving his appointment in geriatrics, he's been actively involved in cross-discipline interactions with other clinicians and educators, and recently co-chaired University Task Force of Interdisciplinary Education. He runs a memory loss clinic that I'd like to know the status of, how that's now coming along, if we're still doing that. It's one of those things I think is hard to keep going considering everything that's happened the past few months. But he has devoted his life to patient care. His clinical interest is how to improve healthcare delivery for older people, especially in cognitively impaired elders and disadvantaged minorities. As I said, he is now currently the director of the Geriatric Fellowship Program, and his presentation topic is health literacy in a clinical setting. And Dr. Raji.
The picture you saw in the introduction was my picture in 1999. Since then, I've grown younger. I'm more energetic. Well, Tony has talked about some of the definition of health literacy. The objectives of my talk today will be that at the end of this talk, we'll all be able to recognize patients at high risk of low health literacy and discuss how health literacy impacts medication adherence, advanced directives, and healthcare utilization. We're also going to describe some of the practical methods to enhance communication, empathy, and care decision making despite low health literacy within the clinical context. I will make this as interactive as possible. And to start with, I want to test, I want you all to pretend as if you are visiting me in the clinic and I'm giving you this instruction. And I would like to know how much of it you retain after 20 or 30 minutes of this talk. So I'm assuming you all have diabetes. So I'm telling you this. Start insulin, Lantus pen, 10 units every night at bedtime. The way we know your Lantus is working is by following your morning fasting sugars. The goal of the morning fasting sugar is 150. If after 3 days of using the Lantus, your sugar is still higher than 150, increase your Lantus by 2 units. For example, increase from 10 to 12. If in another 3 days, your morning sugar is still higher than 150, increase your Lantus by 2 again, and so on. Occasionally check your sugar 2 hours after a meal to see how high it is. Make sure to take your calcium citrate with vitamin D. The goal is calcium is 1,500 milligrams a day in divided doses. Vitamin D is 800 units per day. This is to protect your bones from getting weak as you're on the prednisone for your COPD. Prednisone weakens your bones. Call the clinic in 2 weeks so we can review your blood sugars over the phone, and also call if you have any problems with hypoglycemia. Our clinic number is 409-948-UTMB. I refer you today to the eye doctor. They will be calling you. Next time, we will talk about bone density test. So that's the instruction. After your 25 minutes visits to the clinic, and you're going to tell me anything you remember about that. Anyway, now I don't want to go back to it. This is a definition that Dr. Dinuzzo gave us previously, to be able to use information to make appropriate decisions relating to our care. And again, this is just showing you how serious the problem is, the enormity of the problem. This is just one of the old studies. People have done this study over and over again. In a population of patients 60 and over, close to 80%, could not read or understand basic materials such as prescription label. And I'm going to show you some studies about this, how they do this kind of study. Now, this is more or less re-emphasizing what Tony talked about, that this is not just an academic topic. Being literate in healthcare-related matter is a very important part of communication, safety, as well as oral health. Now, when you have low health literacy, it can lead to poor understanding, which leads to unintentional misuse of drugs, and this is known to be a major cause of medication error, poor adherence, and bad health outcomes. In fact, again, this is another study in the Annals of Internal Medicine, whereby they look at primary care patients. 50% of them do not understand drug label instructions about dosing and side effects. Now, the major part of this talk will be on how we can still function despite low health literacy. We're not going to tell all the seniors to go get a PhD or BSc, so we just have to deal with it and help our patient within the context of this limitation. So, now, there's a lot of emphasis that about health literacy. You must have skills in reading, in listening, and being able to analyze information to make decisions and to apply these skills in health situations. Now, you will realize that you need more than reading skills sometimes to process health information. Now, somebody asked about informed consent, about people trying to get permission for colonoscopy or for lumbar puncture. These are the main elements that patients or their surrogates have to satisfy, the 5 C's of informed consent, which means the patient must have enough literacy skills to be able to comprehend, to understand, and to be able to understand not just the choice that you are making, but the alternatives. The alternatives being the sound you make right now. And then to know the consequences of the choices or no choice. And then to be able, a very important element is consistency. Whatever choice the patient makes, I do not want a mammogram. There should be some consistency in that decision. It's not like I want a mammogram at 11 o'clock and then 12 o'clock I don't want a mammogram. And all this decision making should be within the constant, it must be done voluntarily. There should be no coercion or forced use. And these are more or less the elements. Now, satisfying these elements listed here also apply to a lot of things that patients have to cope with. Appointment for tests and procedures, medications, following directions, Tony talked about this, consent, and preparation for tests and procedures. In fact, one of the most frustrating things in terms of getting things done from our patient is suboptimal preparations for testing. There are so many patients who will need colonoscopy, but understanding the instructions for preparation, the way the doctors or the nurses project the information, sometimes result in suboptimal preparation and constant postponement of these procedures. Again, it's not just ability to read or the number of years of education that is health literacy. Health literacy has several components. Visual literacy, which is to understand visual information. Now, more and more often now, computer literacy is very important to be able to make good care decisions, or to be able to access and use a computer. Information literacy, to seek, get, and apply the relevant information. This is where people with too much education sometimes have problems. They get so much information on the internet, on Yahoo and Google, and then they get confused. And that itself can be a reverse health literacy, whereby they get so much information, but they're not able to apply it in a way to improve their health and care decisions. Then there is numerical literacy, which is very important, on how you divide the tablets, on how many milliliter of a particular medicine you take. All these are very important. The goal is, in the absence of some of these literacy skills, how do we still deliver the best care for our patients? Again, poor health literacy has a lot of consequences. Recurrent hospitalizations, particularly for people with chronic health conditions such as congestive heart failures, chronic obstructive pulmonary disease, and so on and so forth. Recurrent use of emergency services, especially in those patients with asthma. An area that is really affected by education is diabetes. There's a lot of paper on diabetes, in part because this is one area whereby the onus is on the patient to take charge of his or her care, as I read to you on this taking of insulin. In the context of low health literacy, we do know that we have very poor outcomes, both in terms of hemoglobin A1C, as well as in development of complications such as retinopathy, limb ischemia, and other complications of diabetes. Tony DiNuzzo mentioned some of the decreased access to preventative care services, such as mammogram, as well as colonoscopy, which then lead to late-stage diagnosis and poor outcomes. People at risk for low health literacy, the population that we take care of. Recent immigrants, African Americans and Hispanics, people with cognitive and physical disability. And it's not difficult to realize why you have low health literacy in this population. Low education, both in terms of quality and the number of years, low rates of regular reading, language barrier. But more importantly, to the kind of patient we see is because of the high prevalence of cognitive impairments in this population. Think about it. In the 85-year-old population, the prevalence of cognitive impairment and dementia is close to 45%. So when you are dealing with the very old patients, the chance that you have a patient with pre-existing cognitive impairment is very high. And then you're going to give this instruction to that patient. And then we also have other conditions that actually reduce the capacity of patients to obtain, process, and understand basic health information and services needed to make care decisions. The reason why I'm showing this slide is because if any of this is present in a patient, it's very important to address it before you take that DNR as the patient wishes, or you take that agreement to a lung biopsy as being valid. A patient with depression is likely to filter everything through this blue filter. So it might be important to, when you're giving information, and try to elicit the level of understanding of information you give to realize the presence of depression, anxiety, dementia, auditory and visual dysfunction, pain. It's difficult to deliver health literacy or instructions in somebody who is in severe pain. Medications such as narcotics. But more important is the use of medical jargons that we all use, which tend to confuse patients. Again, giving too much information in one sitting can actually impair the capacity of patients to process and understand basic health information. Now, so what do we do to communicate healthcare information despite lower health literacy? The first step is to recognize people who are likely to be at high risk. Patients 65 years and older, the immigrant, people with those conditions I mentioned, dementia, depression, obviously delirium, people with visual and auditory impairments. In the geriatric population, we know this very well. It's always good to involve the family. And if your command of a second language is not at the level of at a level that you can adequately express what you're trying to say, it's always good to get a trained interpreter. And if a patient is emotionally charged, the patient is angry or tense, maybe it may not be the best time to deliver certain piece of information. And when Dr. Grumbles gives a talk about delivering bad news, sometimes you have to ask the patient whether this is a good time to give this kind of information, because the emotional status might impair the level of understanding and processing of the information. Perhaps one thing we should all be able to do is written instruction of the patient visit summary. And I will come back to this later. And to use pictures, stories, and video, just like what Tony is trying to do at the end of this talk, and to ask patients to repeat back the statements. Again, present information in small bits, making sure the patient understands one bit, and then discussing the next one may help improve communication, even in the context of low health literacy. Again, it's important to avoid jargon and to use everyday words. I'm trying to reemphasize the technical jargons and frightening language that we people in the healthcare business we tend to use. Sometimes we want to use it thinking that it's going to make patients comply with our treatment. But what research shows that it actually has the opposite effect. It reduces participation and misunderstanding and can compromise patient ability to make decisions, leading to aggravation of symptoms and slow healing. Let me give you some of the examples that is very common, particularly in the cardiology practice. For example, this is from a paper written, published in the Archives of Internal Medicine in 2004 by Dr. Bedell and colleague. And this is a very interesting example. Consider a patient who has just had a heart attack. The first few hours of uncertainty in the CCU, and that is when the physician might come in and gravely announce, you have the type of lesion we call a widowmaker. Other patients may be told that the next heartbeat may be your last, or that you are living on borrowed time. For instance, you could also use the word, some physicians may want to create a sense of urgency. In a patient with severe coronary artery disease, saying you have a time bomb in your chest. Now, even though the physician might be thinking, we can use this to sort of emphasize the urgency of the situation, but it actually tends to block or reduce the processing of information. So we should all stay away from using this frightening language. They achieve very little purpose. They just create this kind of condition. Again, good communication is part of good medical practice. It's not something we have to do on the side. Health outcomes, patient satisfaction are all improved. It also lowers your risk of being sued. In fact, people have reviewed the literature about litigation. For instance, Dr. White said about 70% of the complaints brought by patients against physicians have to do with communication issues. Sometimes the communication issue is just the lack of respect, and the patient just want to teach that person a lesson. Breakdowns in communication between physicians and patients often lead to patient anger, dissatisfaction, and possible litigation. Dr. Wendy Levinson is the chair-elect of American Board of Internal Medicine and the chair of medicine at the University of Toronto. So it's just practicing good medicine. Now, for some of us who see patients mostly, that you have patients of different ethnic groups, in this community there is majority of our patients, many of our patients are of Hispanic ethnicity. We have a lot of African Americans as well as Asian Americans in our elderly population. So it's important that we all strive to understand not only our own cultural values and biases, but to develop a familiarity with the values and beliefs of other ethnic, cultural, and religious groups. And it's important to ask your patient how they want to be addressed and determine the patient's level of fluency in English and arrange for an interpreter if needed. It's always important to assure the patient of confidentiality, because in some communities, certain diagnoses carry a burden of shame, such as cancer obviously HIV or any other, or diabetes. So it's important to really strike it and say, look, it's a legal requirement that patient health information is very confidential. And again, as Tony said, we should convey respect for the patient in our tone, rate, and style of speaking. And we should frequently check back from patients to determine their level of understanding and acceptance. And I will ask you, which ways do you check your patient level of understanding and acceptance when you give them instruction? What kind of statement do you normally use to see if your patients understand the instructions you give to them?
Ask them to repeat the instructions.
Yeah, that's one. That's great. Exactly. And even now, the JCO is even mandated when you give a verbal order, the nurses have to say, repeat it back to me, so that we make sure we don't give the wrong blood to the wrong patient. So these are some of the statements published by that was written in this Annal of Internal Medicine. Or now we can understand if a patient, you tell the patient, take Bactrim DS twice daily. You can use clarification. Let me see if I have this right. I want to make sure I really understand what you're telling me. I'm hearing that I don't want us to go further until I'm sure I've gotten it right. When I'm done, if I've gone astray, I will appreciate it if you will correct me, okay? And then the responses, if a patient is talking to you, could be, that sounds very difficult to show empathy. Sounds like you are having a lot of problems. That is great. I bet you are feeling pretty good about that. And you can see all these are in your hands, you can read them. One thing that some of the seniors don't like, as a matter of fact, younger people too, is when you are talking to, there are two conditions that are very common in the elderly population. One is hearing impairment, particularly for the high tone. Of course, the other one, obviously, is cognitive impairment. So if you are dealing with patients with any or both of those two conditions, and they have their families, their daughters, their spouses, you still need to talk to that patient, telling them, well, I don't want to give the answer away. You need to take Bactrim DS twice daily because you have a bladder infection. You need to drink a lot of water. You need to take it for 5 days. Even though the patient may not have the memory to register the information, but the patient will still feel that he or she is still important in this clinic. The caregivers, either the spouse or the daughter or the son, they know that they're going to have to register the information. So by asking the patient, you are really validating the patient's importance in this conversation, as opposed to, I've seen this happening sometimes, talking to the, so if you are the patient and I'm talking to your son, did you sleep well last night? Whereas the person is really there, even though the person may be hard of hearing. Maybe you need to write it down and say, did you sleep well last night? So it's very important. That way you also convey empathy as well as respect for the patient. Now this is, if you don't understand what the patient is telling you, this is queries. Could you tell me a little more about that? Is there anything else? Are you okay with that? And talking about respect and empathy for patients, even though this is supposed to be mostly about patient clinical care, but on the inpatient service, when patients get admitted to the hospital, one thing a lot of seniors don't like, and people who are younger too, is when you want to enter their room, you should always knock. I don't know of any patient who will say, don't come in, I'm smoking my cigarette, or they are more than happy to have the people coming in. But it's just good to knock, pause for a few seconds, and then go in. As opposed to the team of doctors and nurses and social workers, you just get in and they won't tell you, but it's something that does not convey a lot of respect for the patients. Now, let's stay with medications because it's directly impacted by low health literacy. Dr. Davis has done a lot of research on what can we do to improve adherence to medications. And I will go through some of the studies, but the conclusion of most of the studies done by Dr. Davis is that you should give single-step instruction versus multiple-step instructions. And that's sort of improve understanding of labels. And also, we should use instruction with explicit time period, such as take one tablet in the morning and one tablet in the evening, as opposed to take one tablet twice daily or one tablet every 12 hours. And the way he was able to come up with this guideline is because of the study that was done in 3 sites, in Shreveport, Jackson, and in Chicago. So what they did, they had 395 patients, and they gave them instruction. For instance, a typical instruction is glyburide, which is a medication for high blood sugar and diabetes. So what they look at is correct interpretation of prescription medication instructions. And the goal is to see how we can improve patient understanding of prescription drug label instructions. So they divided the group into people with adequate health literacy and people with low health literacy. And then the instruction, they use 5 different medications. So they go from the simple to the most complex. So they told these 395 patients, glyburide 5 milligram. Then they give different kind of instruction. In one group, they gave 5 milligram, take 2 tablets by mouth twice daily. What they find out is that 71% of people in the adequate health literacy, they were able to correctly interpret this to mean 2 tablets, twice daily. And only 33% of the patients in the low health literacy group were able to take it correctly. Some of them take 4 at one time. Some of them take 4 twice daily. Don't ask me why, but that's what they found. Now, when they now change the instruction, they just change, they didn't even use more letters. Take 2 pills in the morning and then 2 pills in the evening. The correct interpretation rate for the people who are very literate, it was close to 92%, and this one jumped to 76%, just by changing the language. And when you also use specific times, take 2 pills by mouth, 8 a.m., 2 pills at 6 p.m., again, we have an increase in the correct interpretation rate of the labels. As you can see, regardless of the method used, people with low health literacy, they are still not performing at the level of people with high health literacy, but still much better than 33% and 76%. Now, metformin is another drug that they use in this study. Again, when they use hourly intervals, this is what they find out. When you say take 1 pill by mouth every 12 hours, look at the correct interpretation, 30%. But the bottom line here is it's better to be explicit. It's better to say take it in the morning and take it in the evening, or take it at 8 o'clock and at 6 p.m., whatever time you want to choose for your medicine. That way, you reduce ambiguity, especially for a person with low health literacy. At this point in time, I would like to ask the audience about what is the dose of insulin, Lantus insulin, that's, well, you're my patient now, and for whatever reason, you forgot your bag and you came back right away to pick it up. And I said, wait a minute, let me ask you whether you understand your visit to the doctor. How many units?
10 units of Lantus starting, but I'm also a certified diabetes.
Okay. All right. Which doctor? I told the patient that a particular doctor will be calling him or her. Yes, great. Obviously, I'm not surprised. This is the highest concentration of the most health literate person in the U.S. Yes.
I'm not able to remember these things, so I would ask explicitly that it be written down.
That is, in fact, you just make the point of all this. Despite the fact that we're all, for example, if I ask you, some of it may be from your knowledge. Okay, all right. Goal of the morning fasting sugar is what?
This is that we were going to be tested.
That is another thing. I shouldn't have. But a patient should probably know also that he or she is supposed to remember this because this is his or her life. I mean, literally. So, anyway, the bottom line with this is, I mean, the patient can always go back. You type it down in a good font. As opposed to 10 units, maybe you use 14-point font and break the instruction down. So, writing things down obviously is very important. But the patient is, I mean, even though healthy people 2010, said something about, the onus is on the care providers to effect communication. I think the onus is also on the patient. And if all patients can, they call it the Ask Me 3 program, which is sponsored by the Partnership for Clear Health Communication at the National Patient Safety Foundation. Every patient should be empowered to ask at every clinic visit, hey, what's my main problem today? What do I need to do? And why is it important for me to do this? I mean, that way there is some back and forth interaction such that the patient really knows that there is something to be gained by doing this particular activity. So, and this has been shown to at least force the clinicians to come out and write things down for the patient. The other thing is the clinicians themselves should also form a habit of, what the problem is. You have diabetes. This is what you need to do about it and why that is in your best interest. So now I'm aware of the fact that there's a lot of pressure, time pressure on clinicians in the clinic. Sometimes people have to see patients every 10, 15 minutes. So it might mean bringing patients back more frequently, particularly when you are dealing with medications that have high propensity for toxic side effects. Diabetes medications, medicine for anticoagulation such as Coumadin, antibiotics. If there's no time, it might be a good idea to also use some other members of the healthcare team to help out in terms of making sure the patient fully understand the instruction and directions. That way, you improve the quality of care, you reduce your risk of being sued. It's just part of good clinical care for the patients. Yes?
The last one, I mean, usually patients come in with a ton of medical problems, so do you recommend focusing on one problem for this, or are you going to use this approach for, multiple medical problems that they have?
Well, I will look at the most pressing problems, and I see your point. In geriatrics, you're seeing 15 problems, and then one thing you can do in geriatric is to always let patients have the list of their medications. That is another way to address it, with the indication written in layman's language, And several patients do that. I mean, and you can always update it for them. This is one of the advantages of electronic medical records, because there is a pathway there that allows you to actually print out some of the instructions for the day. Anyway, the conclusion is health literacy is key to effective health communication, safety of medical products, and enhanced adherence to recommended treatments. Low health literacy is common in the elderly, immigrant minorities, and those with multiple cognitive and physical comorbidities. Simplify medication labels, avoiding medical jargons, and writing clinic visit summary can improve adherence despite the presence of low health literacy. Thank you for your attention, and I'm glad to take your questions.
The other thing was in the instructions for the pills.
Yes.
Was that just the verbal communication having that effect, or was that written? When we talk about 2 pills twice a day versus 2 pills.
Oh, written. Written and verbal. Take 2 pills twice daily. What they actually did is to actually let them do it. But they didn't allow them to go and become hypoglycemic. I could have done the same experiment here, but of course everybody's going to get it right. The question from Dr. Mujib was about the study by Davis and colleagues, whether the instruction with respect to taking the medications, glyburide, 2 pills twice daily, 2 pills every 12 hours, was it written or was it oral? It's both. And they actually let them do it, and they see how many pills they are going to take, you know. So, and that's such simple step. From then, I write my prescription explicitly. The common drug twice daily is Bactrim DS. No one comes to my mind immediately. And then take one in the morning, take one in the evening. It's easier than twice daily, or 3 times a day, or thrice daily, or something like that.
Question regarding university. What method was used to calculate the realm to determine level of literacy?
Well, one method, first of all, you get an idea from their level of education. Then you also, what I tend to let them do is to actually, the list of medications they bring to me, the bottles, the brown bag, to read it to me and gauge their level of understanding. That is one method that I use. I don't use any of the formal testing that Dr. Dinuso mentioned in the clinic. What I use mostly is how they were able to understand their ongoing medical problems, and they're able to read the instructions on the medication they bring to the clinic. And if they cannot read the labels on that instruction, or they cannot properly understand it, then I know that's a very strong marker for somebody with potential low literacy. The other markers are the condition I listed before. It's not everybody who is immigrant or Hispanic or African American who has low health literacy, but that kind of led me think about the possibility of low health literacy. The other conditions that I look at are the ones I listed before. Presence of cognitive impairments and other sensory impairments and depression and so on and so forth that I mentioned. Tony, is there any particular instrument that can be adapted from what you presented to use in the clinical setting?
I was going to do that in the next section, but adaptive, most of the forms that are, most of the tools that are used to assess health literacy have been tried to be shortened.
Okay.
All of them have been too long. They're too long to do, to complete, and it cuts into other time to do the patient care. So they've been trying to find and test the sensitivity and specificity a tool that could be short enough and give the information they need. And I think the majority, from what I've seen, are a little more pleased with the Papa right now in terms of it having a wider range of health literacy components that it addresses. The realm is limited. A lot of people still like using the realm. But that's one of the things we're going to discuss is the fact that there's a need for some new tools out there that are better than what's existing.
For me, I run the dementia clinic, and automatically my patient level of understanding is less than optimal. So family is always involved, or some other kind of caregivers, when it comes to giving instructions and direction regarding care.
When you work with dementia patients, one of the things we do in the comprehensive question, you never, this is different, ask a family member to translate. You must wait because of course that violates the very state. What sort of relief or anything do you need for family with dementia patients? Is that an excusable condition in itself because they don't understand, or are you required to have some sort of release or a medical provider or medical executive, things like that?
Well, the simple answer, the question is when you have a patient with dementia and they come in with either their caregivers, who could be family or friends, or even paid caregiver, do you get some kind of release, like a legal or medical authorization to disclose their private health information? Is that right? And use them as to help in understanding instruction. The simple answer that what I do is basically to ask the patient, is it okay if I, if your husband, whatever, you can fill it in, or if Miss Robinson stays in the room with us. Most time, 99% of the time, it's almost self-evident, but it's still a good idea to always ask. The other thing that is recommended in the dementia clinic is to also ask if it is okay to talk with the relatives, let's say the spouse or the daughter, away from the patient. Because there may be some things that the patient's relative want to discuss that he or she may not want to talk about it in front of the patient because it might induce agitation and argument. And you may need that kind of information to actually make choices in terms of the right therapy. But every time we always ask the patient whether it's okay. I've never seen any patient that actually said, no, I don't want you to discuss my private health information or in front of this caregiver.
Thank you very much.
All right, thank you.
Okay, all the other sites still there, and we're going to move forward with our last hour. And this is going to be the interactive portion. We already have a little bit of discussion to understand the options on how to assess health literacy in a clinical setting, really in any setting, and what tools are available out there. I'm just going to give a brief overview. You have plenty of handouts that explain some of the different types of tools that are out there, such as the Realm and the TOFLA, and we'll talk a little bit more about that. There are some more intriguing questions that go a little deeper than just having a tool out there that can be used to measure health literacy. And while I want to give an idea of what's available and what tools may be useful, what are some of the limitations to these tools, as well as what good points do they have, there's something else that needs to be discussed, and that's the implications of actually testing a patient for their level of literacy and how they may react to it. It's a little risky, but so it's a double-edged sword. It's important information to know, but it could really turn off a patient if they don't understand why it's being used. Why is it being measured? There was a study done way in the early 90s by Sharon Bretz, and it was actually a dissertation, that she actually looked at the reading ability for patient teaching and learning. What were the perspectives of patients being tested for their literacy in terms of how they would react to the testing and how that would affect their health care? What really came down to this is, how do adults with low literacy levels respond to assessment of their reading ability? And she was using, at that time, she was using the Realm. Would they be insulted? Would they be turned off? Would they go home? And would it have a negative effect on health care? Just something to think about. So a primary purpose of a literacy screening is to identify the individual's reading ability. But it's much more than reading ability. It's comprehension of the ideas and the instructions and the talk back, being able to give that back. So she pointed out that it's extremely important to understand what exposing one's reading ability and limitations actually means to the adult with a low literacy level. It indicates that for these limitations in a normal context is risky and really should be avoided. Well, now we're seeing that we really need to figure out how to bridge that avoidance and actually do testing that actually will make a difference, because with this video that I'll show you, things could really turn into a mess with poor communication, and you really don't come up with a way of bridging the gap between the health provider and the patient. So the objective is to look at some of these common methods of assessment as I talked about, and I'm going to show this video and have a couple of questions when we break off into groups that relate to the video and looks in terms of how assessing the level of health literacy in terms of weaknesses and strengths that this health provider and this patient encounter is actually demonstrating in terms of health literacy. I mentioned earlier about the 2003 National Assessment of Adult Literacy Survey and the results of that generally showed that at least 12% of the population had a below basic level of health literacy. While 53% having an intermediate level seems to be okay, we really don't know if that's okay. We won't know unless we look at the outcomes. And with this sample being 19,000, that could be considered to be representative of the United States population. I like the question of wondering what's coming up now. Is there going to be a new survey to see some updates on that, and how does that compare to 2003? I think that will tell us a lot. So the challenges, basically that there are limited tools. This hasn't been around very long, and while there is a nice little list of assessment tools that I handed out, there's really only two that is used on a regular basis, two that are used on a regular basis. Sorry about that. Okay. And are these actually adequate in measuring health literacy? And that's something to decide. Is it effective? Are these tools really showing that it will guide me in knowing how to approach communication with this patient in terms of what I can use? Should things be more visual? All right, can I give verbal instructions and they'll be understood? Okay, time needed to conduct a useful assessment. That's obviously a big one. How do we do that? Some suggestion being in the waiting room, if it's going to be a written scale. But we see with the realm that that's done face-to-face, where they're actually talking back and reading a list of terms, medical terms. So what we want to do is measure functional literacy, but it doesn't capture the full range of skills. By that, we have reading as obviously a part of it. What type of knowledge can this assessment show? They can read, but maybe if they see the word written somewhere, they really may not know what it is, but if they hear it, oh yeah, I know what that is. I could tell you there. Okay, lack of familiarity of language and materials, and then the cultural differences obviously is very huge in terms of approaching what health decisions are made when dealing with patient care. The tasks used to measure health literacy are basically organized in three ways. The clinical parts, filling out the forms, looking at prevention, being aware of what guidelines are needed that are age appropriate, such as mammograms and prostate tests. Navigation of the healthcare system I've mentioned several times, and understanding what is covered under insurance. Okay. Are they aware of those things? My experience, and I'm not clinically trained for much of this, which is why I rely on the experts. But I have talked to groups of older adults, and maybe they were a higher level of knowledge, but they were very, very, very knowledgeable about Medicare, what it covered, what it didn't cover. And I don't know if we find that. Yes, Ann?
I wonder if that's because they were familiar before with private insurance. I had known some people who had public insurance before, and so I guess they were used to getting a lot of help.
Mm-hmm.
When they moved into Medicare and things changed, they really had no basis for being able to make decisions. The information, though, was so great
Mm-hmm.
that they were completely overwhelmed.
Yeah. Yeah, I find out that groups of seniors work together really well in teaching each other and keeping them up to date on what's happening. I think the hard part is finding those seniors that are isolated and whether they have an adequate level of knowledge about the health insurance. But yes, if it was private and then moving into Medicare, that would be a challenge, for sure. Good point. Thank you. Okay. All right. Once again, I just want to review that these were the levels. And again, you know, how this is done, it seems to be objective based on being able to complete and answer correctly a certain number of tasks in that survey in terms of what's proficient and maybe able to take on complex, challenging activities as opposed to intermediate, basic, and below basic. And it's one of those things that I think it's the best that's there. And whether it can be improved on and actually tested, I think more studies need to be done that can look at true taking these measures and connecting it to actual patient care and seeing the outcomes that will say that those in intermediate definitely have better outcomes as opposed to those that have either basic or below basic. And that's something that I don't think has been done. I've looked and it really hasn't been done yet. Real quick, and you have these that you can look at. The REALM Rapid Estimate of Adult Literacy in Medicine, I've seen it actually done two ways. Most do it as a word recognition. All right, you'll have the list of words in 3 columns. All right, the first area is more or less on the first column, just to get people comfortable. All right, they could say fat, flu, pill, dose. And you go further down and things get a little bit more complex. They get even more complex in list number 2 and then in list number 3 with that handout. I've also seen it that they don't do this verbally. They'll be given this list and check off the ones that you think you know and are familiar with and can not so much define, but you can verbally say. And it's something you may be able to do. I don't know how good that would be as compared to doing it face-to-face with a patient, but that is an option, and it has been done like that. The problem with the rapid estimate is, for the most part, it doesn't cover a wide range of literacy components. Right? It's mostly word recognition. It doesn't say a whole lot about comprehension. Okay. As opposed to the TOEFL. The short form test of functional health literacy in adults was a new and improved version of the REALM, where it measures reading and comprehension. One problem with the first go around was it was way too long. If you look at the TOEFL, it's a list of questions with fill in the blank with a number of choices to fit, that you can complete the sentence coherently. It took almost an hour the first go around that was tested to do the TOEFL, and then they came up with a shorter form, and so you can probably get the same results with a 6 to 7 question survey on the TOEFL that could be done in less than 7 minutes. Most people really, from what I've experienced, really do like the TOEFL because you can have that comprehension component addressed, which is real important. There's some others. A wide range activity is something that is done for word recognition, very similar to the REALM, except that it's not about health. So most people don't use it. There's a new one called the Newest Vital Sign, and it's simply a nutrition label. And you're able to read the components of the nutrition label, and it not only tells you how much you may know about nutrition and diet, but that these are words that you can express, you can say them, and you may actually understand them. And it's only 6 questions, and it can be done very quickly. Dr. Raji mentioned this, a lot do informal testing that is non-obtrusive. Are there ways of being in the clinic and saying that I could tell this patient has an acceptable or adequate level of reading and comprehension, that I could give instructions, and we would talk back, and with some of the tools that we've talked about, that would be sufficient, rather than having to give a standard tool, standard test. Okay. And there are those out there. Okay. I didn't want to spend too much time because I did want to show the video, and then what I was hoping to do is, if we could possibly break off into groups of 6 or 7, 7 people, maybe 3 groups around here, and just answer these 2 questions. Critique the video for strengths and weaknesses based on the components that you know about with health literacy. How well was communication between the health provider and the family and the patient? How was the use of language? Which types of things seem to be distracting? How would you improve on this encounter with the patient and their family? And it's pretty basic. What we're going to, the video is about 7 minutes. It's about 2:15 now, and then we're going to have time for about 15-20 minutes to get together to discuss this, and then when you're in your group, get one person to write notes, and then we want to hear back from that person in terms of some of the things you discussed. Okay? All right.
Okay, I'm caught up. Now, what else did you want to talk about?
Mrs. Anderson, I am so glad that you suggested a family meeting. I think our family needs to get together. We've been talking, but not talking together. Do you know what I mean?
Oh, I know what that's like. I'm very happy to put together a family meeting for you. We can get everybody to meet here, and I'll be available to answer any questions.
Our family's been upset since Thanksgiving at Mama's house. It was a mess. Mama, you remember Thanksgiving?
Sure, honey, I remember. Everyone was there, and we had a great time. So I let the pie burn. What's the big deal?
The silverware was tarnished, too.
We had a good time.
Mrs. Mays, I'm sure you had a great Thanksgiving. Excuse me. Hello?
Area.
Yes.
Who is this young woman?
Oh, Mr. Hopkins.
She's not Dr. Baxter.
Hospital?
Mrs. Anderson,
All right.
the other doctor's
I can
not
be
here
there.
anymore,
I can be there
Mama.
soon.
Is that so?
I'm sorry. I'm going to have to go to the hospital. An emergency. But we're finished here. Just get back to me on the time and date of the meeting. Mrs. Mays, it was so nice to meet you.
Thank you.
And you.
Thank you.
Feel free to stay in the room as long as you need to talk.
All right, take care. Have a good day.
Bye.
Mama, this meeting is about you. Are you sure you don't want to be there?
I'm sure, honey. I don't want to hear you all argue. I'm okay now. And later, it'll take care of itself.
Let's go home. Mary?
You'll see. The Lord provides, and it's in God's hand.
Hey, man. Glad you could make it. Hey, buddy.
I brought a long way from Madison.
Mm-hmm.
How's Mom?
Well, not too good. She's been slipping lately.
I don't know, Sandy. She looks pretty good to me.
You just don't see it, but I think something is definitely wrong.
Like, what's wrong?
Well, for instance, Wednesday when I went to pick her up for lunch like I do every week, she wasn't ready. She still had her house coat on. She didn't even realize it was Wednesday. She had no idea why I was there. And what about Thanksgiving?
Well, anybody can burn a pie, Mama.
Well, it's not just that. The house was cluttered. The silverware is not clean. Mom always prided herself in the way she kept her table. And the cats are taking over the house.
Well, I guess things were kind of chaotic.
Marion.
Hey, Walter. Hey, old rascal.
so I'm so glad you could come.
Well, it was a bit of a scrape to get here, but this is important. Why don't you go ahead and have a seat over here?
Oh, thanks.
Hello, everyone. I'm Paula Anderson. I'm really glad you could all come today to this meeting. I don't know everybody here. Would you introduce yourselves?
Sure. I'm Marion, and Ella is our mom, and this is my little brother, Walter, and this is my brother, Frank, and this is my big brother, Brian.
And this is my wife, Sandra, and these are our daughters, Teresa and Jocelyn.
Hi. I've done a physical and mental exam, and I've had an occupational therapist go out to the house to see how she's managing. Long story short, it appears that your mom is suffering from the early stages of Alzheimer's disease. I know that's difficult to accept. Are all of you familiar with Alzheimer's?
Well, I work at Shady Pines Nursing Home, and some of our patients have Alzheimer's there.
Then you have a pretty good idea of what's going on.
I don't know much about it.
Me neither.
Alzheimer's disease is the leading cause of brain disorders among elderly people. It comes on gradually, resulting in memory loss, personal neglect, personality changes, and a decline in thinking abilities.
Can it be cured?
No, they say there's no cure. They say it just gets worse.
I agree, Teresa, there is no cure, but the rate of decline varies with the individual.
Where's Mom in this disease?
Well, she seems to be doing fairly well right now. She's remembering to monitor her diabetes and generally taking care of herself. But this is a progressive disease, and eventually she's going to need extensive care. It's important to know that it's going to get worse, and we should have a plan in place when we need it.
What do we need to do?
Well, you're going to need to consider alternative living arrangements. Your mother is not going to have the capability, nor is it safe for her to continue to live alone. Here, I have a list of local facilities that offer service.
Let me see that list. How much do places like this cost?
How will we pay for it?
Well, if Mama has to move, we could always sell the farm.
Sell the farm? I thought that when I finished school, I would buy Grandma out and take over the farm. I can't do that right now.
That farm's quite an asset. I'm not sure about selling it either.
Why can't you live with one of us? Now, Frank, you got a big place, and your kids are out on their own.
Well, I don't think that'll work out. My mother-in-law's going through a divorce, and my wife's been thinking about moving her in.
Daddy, you have to remember, she said that Grandma's in the early stages of Alzheimer's. At some point, she's going to need bathing, feeding, and round-the-clock care. All of us work. Who can do that?
Having somebody in all the time would cost a fortune.
What about the place where you work, Teresa?
Uncle Walter, I don't think that's a good idea. Those people in that place are not like Grandma. They can't take care of themselves at all. She seems like she's still so with it. I guess maybe.
It says on this list that there's an Alzheimer's unit in Orchard Valley. That's up there with you, Walter.
Yeah, I once picked up my friend Sharon. I think Mom would be the only black person there. None of those folks look like they know anything about farming. They probably don't know the difference between corn and sorghum.
Well, that's out. I don't want Mommy in with a bunch of strangers. Sure, advice,
We just can't come to
for the WHISTLE and the Team Ideal program. And it was really to look at how do you come up with a plan of care in a situation like that where you have family members that are disagreeing, and how would you look at the resources that are in your community that might be able to help smooth out some of the issues that were brought up in the video. But I think at the same time, I looked at it and I said, you know, this is something that might be able to show some examples of need for communication and where to go from here, as well as during those encounters. Would there be ways to improve some of that information? Well, how do you think the health provider handled the situation? And if it wasn't all that great, you know, how would you improve on that, possibly? So I'm hoping that gave some food for thought while you look at these two questions, and maybe just take, it's about 2:25 now. We'll get back here at around 2:40, okay, or 2:35, maybe about 15-20 minutes, and see what you come up with. All right. The other sites, everything okay? Thumbs up? Okay.
So yeah, it's okay. It's a little difficult to hear the words on the video. First off, but I think it got a little clearer as it went on.
Was it too loud?
Just kind of muddy, kind of muffled.
Okay.
I agree, Tony, here at Baylor.
But we're gonna discuss it here as a group, and I think we kind of got the gist.
Okay.
It was just some of the language was muffled, so thank you.
Okay. Thanks. Sorry about that. Okay. All right. So I'm thinking y'all can kind of get together, maybe turn chairs around, and think about and just have somebody designated as a facilitator. I think all the fellows can get together.
Hey, Tony.
Yeah.
Savannah from Baylor.
Yeah.
While we're having this discussion, is there any way that y'all can turn y'all's mic down because it's really loud?
Oh, sure.
Just because it's picking up everything that y'all are talking about?
Sure. Sorry about that. Okay. We'll mute. In fact, we'll mute over here. Okay.
Okay, thanks.
I want to sit in.
Doctor suggested family meeting, diagnosis. I mean, they need to share the diagnosis with the family, especially at the beginning of the family meeting, she introduced herself and she asked the people to introduce themselves. So that was good. To do that in the family meeting, you should know who are talking to.
She was empathetic. I mean, she didn't, she seemed concerned, and she provided the facts of the disease at least, kind of explained it a little, and explained the progression.
She had some resources. I mean, she had a list of resources.
During the family meeting, she also addressed, like, she didn't talk only to one person. She kind of, you're having a family meeting, you're discussing everybody during the
In the first part, I was wondering if obviously there wasn't a lot of communication or understanding between her and the mother. The mother really didn't know, and we could blame it on the Alzheimer's, but I was wondering if there was more of an effort to get the patient involved, or is that not something that would be done in that stage or in that setting, just as a possibility? Because more or less, if you notice when it first started, they were waiting. Who knows how long they were waiting while she was doing notes and things? Is that common? Is that something that would cause to not be as